Okay, looks like we're missing 2 members, and we'll get started as soon as they're in the room. Okay, all right. Well, we will move forward. So wanted to introduce our next speaker. We are privileged to have Dr. Leith States. Leith is the Chief Medical Officer, the Acting Chief Medical Officer, and Deputy Chief Medical Officer in the Office of the Assistant Secretary for Health with the Department of HHS. I will refer you to the speaker bio for Leith's impressive resume. That's on the bottom of page 3. So 2 notes I'll make from that. Leith has a distinguished period of service as a physician in the U.S. Navy, and he also told me that in his roles, he has learned to navigate multiple security systems in federal buildings. So apparently in this town, that's an accomplishment. So thank you, Leith, and we look forward to your presentation.
Thank you. Well, good morning, everybody. So I'm not typically a microphone person. Can everybody hear me? Okay, that's true. Okay, I apologize to everybody online. So let me start by saying it's such a pleasure to be here with y'all. David asked me very graciously after my boss, the Assistant Secretary for Health, Admiral Joie, had to respectfully decline. I think most of you may be aware that he recently took on duties as Acting FDA Commissioner. So as you can imagine, his schedule has become quite tight. So I am here hopefully to be a good stand-in for him. And I'm hoping I'm not such a bad consolation prize. I generally would be a sitter. I'd like to tell you that it's because I like standing in front and being in a little power position, but I ran my first marathon on Saturday, and I don't think I trained appropriately because things just aren't right yet. So it got the best of me. It's kind of whooped my butt, so just bear with me. If I'm wincing in pain, it's not because I dislike being here or with you all, just because I'm feeling my age today. So stepping back, I've been in the acting role as Chief Medical Officer for about a year now and came straight from active duty, just like Andrew was saying. In that time, I've been able to be privy to a lot of more senior level discussions around priority areas for the Secretary and for the Assistant Secretary for Health. And the reason David brought me in today was to speak to current activities and kind of frame the perspective that HHS has taken broadly on social determinants as hopefully a good facilitator of developing context or framework for feedback from you all for where AHRQ can take action with regards to the social determinants. And one thing that I think before I launch into the slides I have is that AHRQ is an integral and key member in all discussions within the interagency around social determinants. I cannot go one step without having them as a stakeholder for a work group, for a steering committee. As we all know, it's efficiencies and improvement in care. Obviously, this is, I'll get to, the whole 80-20 piece of, 80% of our life happens outside the walls of the hospital and all that, but there's still a role to optimize what does happen within those walls and improve what does happen in those touch points that we do have opportunity to impact the outcomes of people's lives. So the reason I bring that up is your comments here today are meaningful, they have impact, and they will go forward within HHS. So please don't hold back, as it were. So with that, I'll be brief, just so we can have a good time for discussion and I don't rain on David's parade here. Let's see if I can work this here. Okay, so just framing things from the HHS perspective. We all are aware, and this has been the same narrative for decades, healthcare spending is rising, the proportion of GDP that it takes up is rising, and that does not look like it's going to change based on predictive models that reference historic data. Life expectancy, this is kind of the new veil to things, right? So we've never done very well with life expectancy compared to other OECD nations. Infant mortality and suicide have always languished, but life expectancy at least either maintained or increased. And that's not been the case for the last few years for a variety of reasons, and one of those being overdose deaths related to opioid epidemic, and as we'll talk about in just a little bit, the fourth wave of what this overdose crisis looks like. Chronic health conditions. As a kind of public health practitioner, this one hits, particularly close to home for many of us, I think. 90% of annual health expenditures could be prevented with upstream known interventions that had a targeted approach if they were utilized effectively, partially implemented in the clinical space, in the healthcare space, but sometimes, outside the walls. And then this is another large consideration I think has a bit more of the global security, national security veil to it with regards to emerging threats with influenza, pandemic flu, and probably one of the more recent use cases being Ebola response and development of targeted therapies and hopefully having effective threat sensing capacity in areas of the world that have hotspots that can impact our walls, not just our global partners. AMR and the recent mention I've seen with AMR is how well positioned the U.S. is with regards to our microbial supply. Meaning, do we have drugs in the pipeline, which we do not? Do we own patents? Do we actually own those medications? No, we do not. So there's positioning, looking at how do we reassert ourselves as a global leader with regards to antimicrobial development and ensuring that there's sustainability to that industry. The last three, STIs, HIV, vaccine preventable diseases. This is obviously a huge nexus where AHRQ has major equities. I think everybody's aware of the End the HIV Epidemic initiative. I think, just going through some of the stats very quickly. Over 50% of new cases in 58 jurisdictions in the United States in African American MSM, Latin MSM, and injection drug users. Those are risk communities that have, for generations since the onset of the initial epidemic, languished and not received same standard of care that others have been afforded. So there are obvious opportunities across the landscape from our spending, life care expectancy, chronic disease management, and then looking towards infectious disease that have obvious implications for upstream focus on social determinants that either are bounded by the walls of the hospital in the healthcare setting or outside those walls. Okay, and I spoke briefly about waves of the opioid overdose crisis. Just 2 points from this. HHS has been obviously very intimately invested in the response. Synthetic opioids obviously have had the greatest uptick, fentanyl, carfentanil, and then I think we started to discuss that a bit briefly, and I know AHRQ is already in the boat with us on this as well with regards to seeing this fourth wave of the overdose crisis with cocaine, psychostimulants, such as methamphetamine and other stimulants of abuse, and how we can take the lessons learned from the opioid response and translate that to hopefully a framework that can be used to curb, mitigate, or prevent much of the death, deleterious consequences, and negative outcomes we've seen with the opioid epidemic. Because I think, this is probably the right group to mention this. We all remember the pain being the fifth vital sign. Being able to avoid that, look upstream and see how is what we're doing now going to impact care 10, 15, 20 years down the road? And I think hopefully those lessons are being learned outside of HHS. I know that they're being taken to heart within HHS. And this is just kind of giving more of a veil of what the context of the problem is for HHS. This gets at the overall American health, but as it relates to national defense, from the veil of having a ready supply of 17 to 24-year-olds to draw from because of physical activity level, because of education level, because of history of substance use disorder. At least 70% of potential candidates in the age range would not make it past initial minimum military entry requirements, all services. So that is a problem. It's symptomatic of a greater problem, but a consideration that HHS is taking into account. And then obesity, I know, and actually, this is a little dated. There's going to be glimmers of hope coming out in terms of published material in the near future. Not huge wins, but wins nonetheless, with regards to rate of increase slowing down or showing decrease in certain communities. But this is 2017 data based on NHANES as a projected model, just looking at what's the incidence of obesity going to look like in 2-year-olds from 2017. And obviously you see that goes up based on the predictive model to a substantial majority of the country. So these are problems that have upstream predictors that can be intervened on that historically have not for some reason, right? This is usually one of the more sober charts that the ASH likes to bring up. If there's anything that gets him on a soapbox is inequities and heat maps. And seeing the same heat map over 20 years is something that is obviously not acceptable and is reflective of where you have ongoing, potentially disparate action over a number of years that has not resulted in tangible change. When you have increasing healthcare expenditures, decreasing life expectancy, and a 20-year discrepancy between the best performing zip codes and the worst performing zip codes, there is a huge problem there, and it's a huge shame that we potentially would overlook or just not acknowledge that. So that's another consideration that's now been put into the highlight front and center for HHS. Okay, this is more just continuing to drive the narrative home that this is what we're seeing, where things can happen and things are not happening. Infant mortality, and this lends itself more to even maternal health, and that's another area of developing interest or increasing interest, I should say, for HHS. The example that we're giving here is the Delta region and Appalachia. You have a significant increase in infant mortality compared to the rest of the US, and you have this observed correlation with obesity, smoking status. You can infer a number of things from marital status, and that's not my slide, I won't claim that. But suffice it to say there are things upstream, including poverty rate, that influence mortality that can be intervened on that aren't being intervened on. In a meaningful way, I should say. This is up here not because we subscribe exclusively to Robert Wood Johnson or to the RAND collaboration that developed this outcomes map. But it's meant to show, I mentioned 80-20 before, well, things funneling into health outcomes, 80% of it is independent of, comes before, or after touch points with healthcare. And this, I was going to pull this one out, but the ASH likes to inject his international travels into his talks. The reason I left this in is that it's a nice representation of what international partners are doing in this space. Attending the World Health, one of the World Health Assembly meetings last year, I believe, he was able to go through and do a tour with some of the Kazakhstan polyclinics. These are holistic wraparound service, a way to take these 4 pillars to the communities. So health behavior, genetics, environment, medical care, leading to overall health, hopefully. Note how small the band on medical care is. Again, it's just reflective of where are people going to put their equities, put their sweat, put the time and effort into. It's not an unnecessary component. It shouldn't be an afterthought, but it's just a recalibration of what historically we think of when we think of health. Again, just driving the hammer home, and I'll speed up, I promise. I know everybody knows these things well. This is just giving you the background on HHS and where we stand. Cancer cases, preventable. Nearly half could be taken off the books. We would not have the need for the chronic disease management, the associated comorbidities, the chemotherapeutic, the XRT regimens, the decreased lifespan, the decreased quality of life, QALYs, all the GIPLs, all the good public health terminology that we want to use. If we adhered to, implemented those preventive measures upstream that we know prevent cancer well. And try as we might, and I think we've all had concerted efforts that, at the bedside, we're going to have these lifestyle measures that we're going to talk about. We're going to talk about smoking. We're going to talk about alcohol. But there's something amiss in how it's been implemented. And it's one of those definition of insanity things. You can continue to do it, but at the risk of what? So again, just looking at another example, and cardiovascular mortality. The number 1 killer could prevent over half of those deaths if, we prescribe to the usual things that are kind of soft calls. And I think HHS is as culpable as any in this. Guidelines, recommendations are wonderful, but there's something amiss between, developing the need for behavior change or the actionable behavior change that results in tangible outcomes and improvement in health. And I think this is one of the final examples. This is physical activity, kind of rounding out obesity, nutrition, and getting to physical activity, having $117 billion attached to low levels of activity and increasing preterm mortality, all-cause mortality. Well, I misspoke. So we also had, everybody's aware of kind of the healthy aging approach and some of the things we've done within ODPHP with regards to kind of the Healthy Aging Summit and having that get some highlight. It's becoming a more concerted effort for the Secretary and I guess a recalibration of efforts that there's been so much put into the research end of drug development and novel therapeutics. NIH has obviously taken that for action, and it's a very robust area. And obviously, understanding, elucidating pathophys and biochemical pathways are hugely important to understanding disease process and where you might intervene. But I think there's been a recognition, understanding from HHS that there may be another way to supplement, augment that work that's being done in that preventive upstream space. All right, now, this is meant to just say social determinants are not skin deep in terms of the impacts they have. There are biological changes that occur. There are 3 slides I have here I'm going to breeze through for the interest of time. But things such as, the biology of having social determinants attached to poverty, whether that be hookworm or HIV. Having adverse childhood events affect your brain modeling, your brain architecture, the way you cope with and develop your stress response, and having that result in, future poor coping mechanisms. I can speak from experience on that with regards to kind of the PTSD standpoint. Once that architecture is in place, once those pathways have been further, emboldened and strengthened, it's difficult to come back from that. And obviously can set you up for a lot of those other relevant considerations and social determinants that just facilitate a life that ends much shorter and much more unhealthy than others. And then the consideration on epigenetics, and I know this can be a controversial one. I won't go into the nuts and bolts there, but think, having some type of external stimulus, external exposure, child abuse, whatever the case may be, and having variable expression of DNA that can result in, differential pathways being reinforced, or just a setup that contributes to, in the context of ongoing stressors associated with poor outcomes, the likelihood that life will not end up as well for you as it is for others. Sometimes determined not solely by the zip code, but obviously much more so than what your genetic code would tell you. So typically at this point, it's kind of the so what. We all know these things. We've all seen that outcomes are bad. We know that there are disparities, racial, ethnic, whatever the case may be, and nothing's ever done. The needle doesn't move much, and we just kind of go on and live the life that healthcare is going to live. You're going to incent fee for service. You're not going to focus on public health. It's just going to go on and be ad nauseum, just the same old thing. And I don't put this up here because I love the Secretary and I toe the party line. I think he's a great individual and a wonderful leader. But I bring it up because of one of his pillars, which is value-based care. And though it's been present in previous secretaries charged to HHS, I think there's been a significant culture shift in the way the delegated leadership, so the assistant secretaries, the directors, the administrators, the commissioners, have taken this for action and actually internalized it into much of the activities that the op divs and the staff divs are doing on a daily basis. And just to give a couple examples from OASH, this is part of our new strategic plan with regards to health opportunity, transformation, innovation, and response. I'll go into that a little bit more, not much, but just suffice it to say this is a product of my boss, the Admiral, taking to heart some of the things that have been, we've been guided to do with regards to value base. This is a better characterization of what that looks like for us in practice. So we have a very broad portfolio within OASH. Some areas with prevention, with treatment, with frameworks that help us interact with our stakeholders better. But the thing I want to point your attention to is that a critical consideration for every move we make is the health disparities that you see on the left. There's also obviously been a large pivot towards rural health. Obviously, we have Rural Health Day out there. Racial, ethnic considerations, gender-based, and then age and disability. For all of the areas of interest on that screen, there have been steps in the past or existing pathways that are existing processes in place that disenfranchise further a group that is at risk. And our goal within OASH, and I think broadly in HHS, is to help bring those folks into the light, to receive not equality, but the equity thing. I know it's the cheesy picture of the kid with the fence and this is what equality is, this is what equity is, but this is where it can help actually come and take shape. So an example I'll give is sickle cell up there? It is. So you may be aware that Admiral Jawad is a staunch proponent of improving outcomes from sickle cell disease. He wants to improve mortality by 10% in 10 years. That is built on the assumption that there's something broken in the way that existing modalities to improve outcomes have not been utilized. And the reason I bring it up for the AHRQ group is that things like compliance utilization of hydroxyurea, penicillin prophylaxis, transcranial Doppler utilization, these are all things that are used in the clinic. These are things that improve outcomes, that will keep kids from having strokes, from having pain crises, from having early death. Independent of, great new CRISPR meds that can help cure and also cost a boatload of money. But it's doing the small things well, using well the tools that you have. So that's the reason I bring that up. And then I'll give a mention to cardiac arrest and CPR because it's one of those non-classic public health things. It's an end stage of cardiovascular disease. It's about 350,000 of those cardiovascular mortality cases that we talked about earlier. There are significant disparities there. If you are an African American, you have twice the rate of sudden cardiac death, but you also have a 50% less likelihood of receiving bystander CPR because of the zip code you live in. So these are all considerations along the spectrum from genetic conditions all the way to lifestyle and potentially some genetic contributing factors to a disease state that could be prevented from having such a terrible outcome. And just a couple slides on current ongoing work. And I'll just read one blurb here. So this was a National Academies contract that OASH did earlier this year. And the goal was to essentially look at return on investment for health-related social needs, non-medical health-related social needs. So essentially stating the business case to non-medical, non-public health folks. We've actually taken this for action and utilized quite a bit of the recommendations. And one thing I'll cite is the Surgeon General. He has an ongoing initiative for community health and economic prosperity. And he's made it part of a larger initiative that's going to hopefully release later this year. And the whole goal is just to start to speak the language of the business community. It's not just having an employee health program, because those have obviously shown themselves to be woefully insufficient to actually affect change in the health outcomes of employees. Is getting out into the communities, actually investing in the community that you have your operations ongoing in. And I think everybody is familiar with healthy people. For me, it's been kind of the common language of social determinants and has been readily applied by state, local public health agencies, healthcare systems. It gets utilized very heavily within HHS, and I know it's something that we are basing much of our continuing social determinants efforts around. All that to say, Healthy People 2030 will be coming out in March. And you all are probably aware that there was a significant cut in the number of objectives, went from something like 1,200 to just shy of 400. And the criticism that was received was, well, you're kind of trying to boil the ocean there, Healthy People. And it's one of the, if everything's important, nothing is type constructs. So the reason I'm leaving that up is the social determinants considerations have not been dropped in that cut of objectives. I'm fortunate to be able to take a look at some early documents, and there are over 60 social determinant-centric objectives and tags still remaining in Healthy People 2030. These are just a smattering that are still publicly available. But suffice it to say, it's still a central piece of what's going to be the kind of the metronome for healthy people going forward. And this is the last slide I have. And everybody's aware of the Primary Cares Initiative. I don't need to go into this. I know Sherry Ling over there could do this much more justice than I can. It's an example of utilizing CMS levers to help direct transition towards a value base. The one thing I want to leave you with is that there is so, and I was talking to Sherry and David about this earlier, so there's so much it would be nice to chat about, but that I'm getting used to the fact I can't talk about much of the work I'm doing. It's so encouraging, it's very exciting, and I think the exciting part for you all in the audience and online is that your comments today can help contribute to these ongoing discussions and are truly valuable and need to be heard. So with that, I'll close, and thank you for your time.
So thank you, Leif. We'll open it up for some comments and discussion. The first person I'd like to turn it to is Don Goldman. He had a comment.
Yeah, hi. Thanks very much. That was a really wonderful presentation, literally packed with great insights. And I especially appreciated your calling out disparities between African Americans and whites in this, as well as your emphasis on allostatic load and its effect on epigenetics. Very advanced thinking. Just a few comments that are comment questions, I guess. One is about the interesting in the global sphere and what other countries are doing about social determinants. And it would be good to hear you speak as to whether we are paying attention to the Sustainable Development Goals and intend to meet them. People think they're all about Africa and underdeveloped regions in Asia, but actually many of them are absolutely appropriate for the United States, including access to clean and safe water. The second is that, and this may be a little pedantic, but I've become very interested in Paulo Freire's teaching. And what Paulo Freire says is, if you don't name it, you can't address it. And in all of your discussion there, I did not hear the word racism, and I didn't hear you address structural racism. And I wonder the degree to which, when you're having your conversations at HHS, you talk about what you're going to do about the blatant racism in the United States, especially structural racism. And finally, you showed a lot of heat maps, and you could show 30 or 40 more, and they would invariably show that the worst health outcomes are in a certain region of the southeastern United States, always colored red. And I wonder what the theory is as to why it is that that region of the country always finishes near the bottom in almost every metric. Thank you.
Thank you for all the questions. I will do my best to address those. Going with the number one, with kind of the global considerations. Our office in OASH, we recently were tasked with adopting one of the centers that came out of the Reimagine process here at HHS, and that's the Center for Health Innovation. And much of what's informed the development process over the last year and a half has been facilitated by ongoing work in Europe, and that looking at their ability to address in probably a much better way some of the things that we're looking to enact with regards to innovation around the space of value-based transformation and social determinants. So that's been one of the larger considerations. And I think, in terms of lessons learned with regards to other areas, we still, we haven't fully implemented the HIV epidemic initiative, and hopefully, I know there was mention of the CR earlier. Fingers crossed, we'll be able to fund that initiative and have that continue to go forward after signatures get in place. But much of the lessons learned in terms of how to effectively address incident cases of HIV has come not from our own, lackluster work here in the U.S., but from what's been done on the African continent. So I think there's, a role for that kind of knowledge sharing and hopefully, humbly accepting where we need to take our cues from. And I think that's been borne out those are two examples. I can think through some more, but in the interest of time, I'll try to take the loaded question of structural racism. As you can imagine, I mean, there's an audible pause for most folks when you start to mention those words, and it's because it's still real and it's not going to go away. These are obviously multifactorial things that are outside of the control of HHS. What I will say is that HHS does not take the position that they have the cure-all for all social ills. Every initiative around social determinants that I've worked on so far has included justice, education, labor, HUD, USDA, other partners, if not external in the private sector, to help contribute to a holistic look at what the problem is. On that note, I think one of the important contributions I should also say is that there's been more than just an implicit understanding that there's structural racism at place in the way government has responded in some instances with regards to public health ills of the day. I've been really fortunate to go on a couple of the listening sessions with Dr. Redfield from CDC as it relates to the 58 jurisdictions that are going to be highlighted for the HIV initiative. The goal has been not to tell folks what they need to do, not to tell local communities how they need to do their programs, tell them not how they need to identify, treat, and retain and care their members of their community with HIV, but instead hear from them what is going to work for them. So I think it gets back to empowering individuals and communities and not telling people what they need to do or being prescriptive about what is going to work for them because it worked for, this, small sample size of 18 to 40-year-old white males from the Midwest. So that also gets, and I'll get off my soapbox soon, but that gets to research as well and having a bit more equity as it relates to clinical trials, to have drug development that takes into account not just, those that have the most in society, but those who are going to stand to benefit the most, right? So think of the case of the sickle cell and drug development with some of the curative therapies. I think there was a release from Novartis and FDA about conditional approval for one of the medications, one of the select inhibitors, and that would not have been brought to bear without African American patients. There is a huge role to understand that everybody is equal, but everybody's response to medications is not equal. And I think that's huge, not just in the genetic conditions, but also with the broadly, chronic disease, with heart disease, with kidney disease, with hypercholesterolemia, just the usual things that we treat with abandon, like with Lipitor, with HCTZ. These things don't work to the same efficacy as other communities. So these are all things that contribute to why the Delta, why the South, why certain regions of the country do not perform as well. I think it's because they haven't been invested in, and that's reflected over generations. So I'll get off the soapbox there.
Yeah.
So that was
thank you for that, and do just note that it is a very complicated and undoubtedly long-term effort to deal with racism in America, and particularly structural racism. Structural racism is reflected in policy, and the one thing that I think HHS can do is to get past the point where we have a sudden uncomfortable pause when somebody says racism, and HHS start using that terminology. You can't talk about social determinants without talking about equity. You can't talk about equity in America without talking about racism. So just changing vocabulary will rid us of that really deplorable fact that we have to have a uncomfortable pause.
So thank you, Don. And obviously, there's a lot to unpack on this particular topic. Before we open up for broader discussion, two things. Jerry Penso has joined us as a council member, and then I would also like to turn it over now to David Myers for some comments.
So thank you, and thank you, Don, for forcing us right away into the big questions. You have a talent for doing that, and we're going to miss that greatly. For those I haven't met before, I'm David Myers. I serve as AHRQ's chief physician, and recently began serving as our acting deputy director. And before we get into this debate, just a tangential note to the NAC members, I am not the permanent and will not be the permanent deputy director. We need all of you as advocates and ambassadors for AHRQ to shake the trees and help us find the right person to fill that role with Gopal. We sent you all the announcement today and any other time. Reach out to Jamie, reach out to me, reach out to Gopal with ideas of people we should contact or information you need to help get the right people to apply. Okay, that said, we're going to come back to this discussion. As for the new NAC members especially, want to set the context that AHRQ uses you truly as our National Advisory Council. We turn to you for information from outside of the DC Beltway and outside of our HHS family to help us select the highest impact projects, the places with the greatest need that we as AHRQ have the greatest chance of creating goodness from. Sometimes, like you heard earlier today, we come to you when a project is nearing its end, and we show off the great work we did, which I am so proud for Ed of what he and his team have done, and ask you, what next? That gives you a certain framework to bring to us, but it's different than what we're about to do. SDOH, Social Determinants of Health, as you heard, is actually not new at AHRQ. We've been doing this for our entire history. But it's taking on new meaning and new importance. And we are undergoing a process of saying, what should our role be in moving this forward? As you've heard from Gopal, our mission is to help healthcare systems and healthcare professionals improve the quality, safety, and value of the care they provide for the purpose of improving the health of patients. We are definitely in the healthcare system. So there are choices we have to make in this larger context of social determinants of health, frames that we can put together and then focus on where we are. We're turning to you as people who represent healthcare systems, represent researchers, represent patients, to say and to speak to us about your experience today of what the community is feeling about this very, very large and complex set of SDOH. To do that, we provided you some background reading, and I want to highlight two parts of that. One came out of the National Academy of Medicine, and if you read that, you can see there is a tension, especially for healthcare systems, in approaching the social determinants of health. It recognizes that as healthcare professionals, we often approach the individual patient before us. And the language that's often now being used is meeting their social needs. Everyone has social determinants. It's a universal phenomenon on multiple dimensions. But individuals have needs along those continuums. And the ability to understand what a person's need is, to adjust the care plan or address those needs, is something we do on an individual level in healthcare delivery. There's a second side of that continuum that says, as large organizations employing many people, delivering care, having relationships in communities, healthcare organizations, whether they're insurers, entrepreneurs, health systems, all can be involved with changing policy, creating new societal structures that address social needs and actually get at the root causes of social determinants, creation of inequities in health. And the NAM called that advocacy. We could, at AHRQ, be anywhere and multiple places along that spectrum. So I'm going to ask you a series of questions over the next 45 minutes that I'd like to take you through in order. The first starts with, as people out there, What are you experiencing? What are your organizations thinking about? Is this even on the radar? How are you thinking about issues of social determinants on the individual delivery or the societal level? Just conceptually, is it on your radar? What's important? What are the, again, channeling Director Khanna, what are your pain points when you think about this issue? Then we're going to go to a second level of question, which is, are you active? What projects and programs, and this is where I'm going to ask my federal colleagues, I know how to get your answers to this. So to the rest of you to tell us both things that you've done that you think are successful, that you're proud of, that your organizations want more of, and the places where you've tried to act and are having challenges. So the failures, or the not as successful as you'd like, that we want to hear about. With those two as background, then turn the group to ask the question, what do you see as AHRQ's role in helping you address those challenges and those activities you'd like to take? And that's why I want to thank, again, Dr. States for providing you an overview of what AHRQ is doing within the Department of Health and Human Services. We gave you a handout that just briefly, at the highest level, showed you some of the activities we are already involved in. We had many more examples, but we broke it down into AHRQ's 3 core competencies. AHRQ invests in developing new knowledge through health systems research. We answer the questions that people don't know the answers to. We create tools and training to help healthcare systems and healthcare professionals implement change, put it into practice. And we also have a focus on data and analysis and measurement that drives both research and practice improvement. So within any of those areas, our final conversation is, where do you see the greatest gaps, the greatest potential for impact, the most feasible places to start? Make sense? Mostly seeing people shaking their heads. So with that, and we would have loved to invite you for a whole 2 or 3 day symposium where we could have unpacked how to use language, what is the current knowledge, what are the larger things AHRQ should be advocating within HHS, what should HHS be doing outside of AHRQ, CMS and the VA, the ASH's office. But given that we have limited time, we're going to focus on those 3 things. Y'all telling us, what does this really mean to you in your worlds? What's your perspective? 2, what is already happening out there that we need to know about, both working and not working? And then finally, where do you see the greatest opportunities for AHRQ in this space? And around the room, it's really exciting for me to be able to be the facilitator here, but there are many, many thinkers and doers from all of AHRQ's divisions who are already actively in this area, who are going to listen to what you say, and we're going to take it back. And as I said, that's what you do as the NAC. You will see over the next 2 to 3 years the fruits of what you've done as we put it into action. So thank you. And Andy, you can.
No, so thank you. Excellent tee-up for what I hope will be sort of an in-depth, granular discussion. There's 3 of the council members that I would like their perspective on, just as a starting point to the first question. What is our, in terms of a system-level approach and philosophy on how we tackle a very complex issue of social determinants of health? And one person, I still practice part-time in hospital medicine, and what I would ask Beth for some comments, being a frontline nurse, a floor nurse in 2019 is a very complicated job. In what ways are your staff dealing, and that has direct implications on how they interact patients, the discharge process, communications with families. To what extent are your frontline nursing teams and frontline care providers in your organization aware of this, and how do you frame the problem for them?
I think it goes back to, keep in mind, I'm from a critical access hospital and it's rural. So I just want to start with that as part of the conversation. It's having the caliber of nurses who can care for people in rural communities that are of a higher acuity, that don't have direct access to acute care, tertiary care hospitals. We're fortunate enough to have that access. However, because of the load at the tertiary care hospitals and the volumes they're experiencing, they want us to keep our community members home. The other variable is people from small communities do not want to go to the city. They want to stay home. So it's making sure that we have the education and the resources in the rural communities to provide that care. And I think rural communities have a greater stigma for not having that health care as we speak about disparities. They have a higher sense of isolation. They look at, in our rural communities, people do not have the education that they have in the urban area. So how do we do that? So I was very glad to see rural was at the top of your list because I think there's a huge gap there. And I think the gap is on both ends of the continuum, from the aged patient to the newborn infant and infant mortality. So it's on both ends of the spectrum. So from a nursing care perspective, we have to be a generalist in a critical access hospital. We have to provide that care as a generalist. And in today's world, being a generalist is not always the popular thing to be. Everybody wants to be specialized. I think even as we look at our primary care physicians, we experience that as we saw those numbers drop as well. So I think those are the things that we have to work on, and I think we have to look at nurses as part of that continuum as we look at and physicians' assistants as well, as we look at different levels of care to help support those primary care physicians in especially the rural communities, but across the continuum of care. So that's how I see it from my perspective.
No, and I think sort of a classic example is we spend a lot of time on medication reconciliation as sort of as a marker of quality of care. However, it doesn't matter if you have the list right if they can't afford the medication or they can't access the pharmacy to get those things filled. So I think there's a recognition that it's much more basic. Many of these things are sort of peer-to-peer interactions, not necessarily medical care. So I think that is an opportunity in terms of empowering our workforce to start to recognize those things and prioritization. The other two people I would ask for comments on, or comments from, would be from Chris and Barbara as sort of organizational leads in patient safety. To what extent is the social determinants of health conversation a safety factor, and how does it relate to adverse events, and how is your organization trying to incorporate that into its program?
Sure. So I'm happy to take a stab at that. I think it's safe to say I'm from MedStar Health, and we have 10 hospitals and about 300 ambulatory sites and a visiting nurse service agency. The issue of social determinants is on everyone's radar screen. It is everywhere, every day. I'm doing some research right now with our primary care providers, getting them to diagnose and treat patients with hepatitis C virus in their practice, and it's a workflow issue. It's interesting that our case discovery form didn't have enough social factors on it when we got the groups together to talk about cases. It always reverted back to the social history, the social determinants of health that were impacting the capacity of the individual to receive treatment, to follow up on treatment, et cetera. I think in the patient safety space across the board, I mentioned that social determinants are on everyone's radar screen. We run the risk of doing really great things and not knowing what to disseminate, what's generalizable. You know, we're living by anecdotes. People that are really passionate about doing the right thing, we are trying to tease out how these factors impact patient safety. So we look at our patient safety events and are beginning to stratify by which patients are impacted by patient safety events. You know, we have great capacity to drill down to zip codes, to drill down into some other data that says, why is it that in our inner city hospitals and in our rural hospitals, patient safety events of similar types might be more prevalent than they are in, I'll say, some of our other hospitals. Mm-hmm. We don't have the answers to that yet, but I would say I see us thirsty for the capacity to begin to organize our efforts and learn from other folks that are doing similar pieces of work. I think the notion of research to understand what is generalizable and what is not, we have really strong community partners, FQHCs, community health centers, housing and urban development groups. We have a growing cadre of community health workers. Talk about a powerful group of I'm going to say support staff that are really helping us bridge that gap, but they come with more questions than answers. So tied to patient safety, absolutely. How? I could list 1,000 ways, and I don't know if they're one-offs, or if they're really something that's worthy of it's food, it's medicine, it's money, it's education, it's substance use disorder, it is, inability to get a job, it's legal services. We have, in our Georgetown ED, we have legal services there. Because what we find oftentimes is that what brings people to the ED is that there's stuff going on where they need some other kinds of help. So I'm excited to listen. I don't know that I have much to offer at this point, other than I think this is the place for AHRQ and others to really begin to focus deeply.
Barbara, is sort of from the perspective of patient safety advocacy group, how do you frame this up?
So actually, thank you very much. So the Betsy Lehman Center, I think, is often thought of as an advocacy group, and we do think of ourselves as advocate. We're actually a state agency, and the Massachusetts State Patient Safety Agency, and so we play a role in research and in convening and dissemination, which is not unlike a very mini version of AHRQ, but on a state level. And we are actually a big consumer of AHRQ resources in this area. So I would say, and I agree with Chris, that social determinants is very much top of mind, and there's plenty of research out there, probably much of it funded by AHRQ, that has demonstrated that in terms of safety outcomes at the system level, big system level, any number of vulnerable populations are faring much, much worse. And the question is, how do you how do we tackle that as a system, and also what is the role of healthcare providers in addressing that, and what are healthcare providers uniquely situated to contribute? Because in Massachusetts and in Boston, I think one of the first, Boston Medical Center had, I think it was the first legal services program in a hospital that was, and the question is, there's always a question about, is that really the best way to go about this? Are healthcare providers the experts in addressing that, and should there be greater collaboration? The other thing I want to mention is that we are in the process of we've convened a statewide consortium on the Massachusetts Healthcare Safety and Quality Consortium that's working on a roadmap to safety for Massachusetts, which is essentially a statewide strategic plan organized around 4 pillars of safety. I won't go into the details, but we have close to 40 organizations in the state involved in the consortium, including the State's Hospital Association, the Massachusetts Medical Society, health plans, a variety of consumer and patient groups. But in convening that consortium, which is always, and it's a very energized group, and we're making some good headway. But in convening the consortium, it was interesting to me that the hardest sell to get in terms of organizations to get to the table were organizations representing many of those vulnerable populations, and it part of it is a low awareness of safety issues in general. What are you talking about? Patient safety. Part of it is thinking about when they're thinking about healthcare, and these are not necessarily specifically healthcare advocacy organizations, but population-based advocacy organizations. When they think about healthcare, oftentimes the issue is access and costs, and it's like, well, we don't need to worry about quality and safety if we can't even get access to it, and that's just not where we can spend our time. And so there's a real, but we understand that those voices they have to be at the table. And so the question is how, it's just a sort of a challenge in sort of the capacity of many of the communities that are most affected by this to engage. And is there some way that we can help build that capacity? And I don't think we don't have the answer to that, and I don't think anyone has had the answer to that. So I guess the bottom line is very much top of mind. But how do we what exactly do we do?
And Peter, I'll get to you in just a minute. I would just ask for if two of the council members we haven't had a chance to hear from yet would have any thoughts on this. So Jerry, what do you hear when you work in your work with medical groups in terms of resources? How do they, many of these are private medical groups, how do they sort of engage this problem? And then from Tina's perspective, I would say, how can technology help solve this, in terms of a high-level approach? So any thoughts along those lines?
Yeah, I'll start, and excuse me, I have a little bit of a hoarse voice, so I hope you can hear me as I whisper through this. I would say it's also very much top of mind for many of our medical groups and health systems, especially those that are moving to value-based care. Because as you move to value-based care, you understand that if you want to get the best outcomes and lower costs, you have to go upstream and address some of those social determinants. You can't get good outcomes for patients with diabetes, for example, if they can't get to their appointments, can't afford their food or get their meds. So it's, if you will, sort of forcing those sort of discussions going on. With that being said, what I would say is huge variation in how those groups are beginning to address, and I would say we're at a very early stage. Screening is one of the biggest challenges. How do you screen? What's the best way to screening? How do you then understand and use that data to formulate programmatic responses? In addition, as you mentioned, many of our groups are already taking action and working with community partners. Geisinger with their fresh food pharmacy is an example. Many are working with transportation companies like Uber and Lyft to work on the transportation issue. So again, I think one of the issues is what is the effectiveness of these programs? And how are we going to measure effectiveness? I think those are just some of the issues that are on the table.
Yeah, no, so thank you. And I would say, I think you hit on something that's very important in terms of variability amongst city, state, regions in terms of what you might have, family in Massachusetts, what they have access to and some of the social support services there is vastly different than you might have in other states. And I think in terms of solutions, as we move into the solution phase, I think trying to figure out ways to address that variability and sort of level the playing field is it's a complex question, but important. Tina.
Yeah, and so, several of us are just coming from the American Medical Informatics meeting where there was a large track on, technology and informatics to capture, assess, and present this information in the clinical domain. There's a lot of issues right now with both capturing the data at point of care, how is it, are there validated questionnaires to capture this? Is it from the patient? Is it the clinician's interpretation of that? So all the same issues we have with a lot of other PRO information. There was also a lot of interesting discussions in how do you bring that back to the patient, right? So what type of technology can you use so the patients can see, where they fall on the spectrum? And I think that was also an important conversation that was ongoing all this week in our meeting. But a lot of the conversations were that I've been following are around, going down into the granular clinical information in the EHRs, so narrative text, et cetera. That can be a rich source of that data. But again, there's no standardization on how to capture that. How do you use it? How do you incorporate it into clinical analytics, into predictive analytics, et cetera? And so I think there's a lot of gaps, but definitely movement in this area. As I said at our meeting, there was a whole track on this topic, and so it was just integrated throughout all the sessions. Very, very interesting things going on. But again, lack of standardization, lack of metrics to capture or tools to capture it with is going to be a bottleneck.
Thank you. And so with disclosure that I went to medical school at IU and did some training at Regent Strife, which the county hospital there is the exemplar of social determinants of health, I'll turn it over to Peter.
Thank you. Yeah, no, that's great, and I agree with absolutely everything that's been said. So just making a few notes into David's questions, just wanted to try and run down that, and I'll try to be brief. So critically important, at the Regan Street Institute and working with our partners like formerly Wishard, now Eskenazi Health, our county hospital, really obviously a lot of focus on this. Going back now almost 3 years, one of the first strategic initiatives I started when I got to Regan Street was essentially a complement to what we had been doing for the bulk of our history over the last well, we're celebrating 50 years, but certainly over the last 20, a lot of work with the health information exchange activities that people are aware of, and how we need to pull together and be able to traffic in health data, healthcare data, I should say, across health systems, taking that same kind of approach and methodology and importance and saying, how do we now apply that to this realm of social determinants, recognizing the 80-20 rule and the fact that this is so critically important. And as has been said, very much an item of discussion for our field, for the research domain in terms of how do you even do this, what are the standards we need, how do you traffic in this, and obviously layers of complexity, because to some degree, as hard as it's been to do this in the healthcare system, at least we were just dealing with the healthcare system. Now we're dealing with literally everything. And so it becomes obviously very thorny, but even that more important, and that much more promise and potential and excitement, because now we can potentially start to really get a view of the entire person, and really this movement from health care to really human care, right? We're not even necessarily talking about patients anymore when we're talking about this, and we have to start thinking about it that way, and we all recognize that. That factors into all of this. So just a few concrete examples to sort of go down the list of what you enumerated, David. So one on the research front, again, a lot of informatics research to be done, as Tina said, a lot of activities around how do we go about actually trafficking in this information, collecting it, storing it, exchanging it, standardizing it, bringing it to the right person at the right time to make the right decision, et cetera. How do you incorporate not only the technical components of that, but then also the policy implications of that? What does that mean for how we set up our system in terms of informing incentives around payment and connections to what health systems are doing? Now, what are we seeing as we begin to interact with our healthcare systems, which was another part of your discussion? Certainly, for instance, with our healthcare systems in Indiana, working, for instance, with our safety net hospitals and the federally qualified health centers, but also with our large health systems like IU Health, what we're looking at there is an increasing recognition from them that they need to be trafficking in this information. They recognize the importance of it. They know that's what they need in order to be able to manage their populations. They're starting to just make decisions about investing in systems that allow them to even be able to capture some of the information and then be able to connect to community-based organizations that can deliver the kinds of services that are necessary. But they all recognize that we're at a very early stage. It's very nascent, very rudimentary in terms of what we're doing. But they have to begin because they recognize they can't wait for it to be perfected, which is appropriate. But we're starting to do work with them to determine, okay, how can we make this better? So just one concrete project, we're looking at, we've actually started to geocode our information and pull other data sources in, which thankfully we have a lot of robust resources in Indiana to be able to bring via decision support or other tooling. And I thought about this with regard to Ed's tool. I think the CDS work very well could be applicable here. How do we now bring that kind of decision support to the point of care and to individuals so that, for instance, in our case, we have a project we call Upstreams where we take these data, integrate them together, and then provide them back at the point of care to inform wraparound services for individuals who come to clinic, so that we know that we can prescribe or refer not only their medications and their follow-up visits and their referrals to other healthcare providers, but also to financial services or legal services or transportation services or food services when they go home and those sorts of things. And we're starting to see changes, and there's evidence that's coming from this, but more research needed on how those kinds of applications and resources can be applied at the point of care to actually change outcomes. And then I'll end by saying I think we're also starting to recognize, and we're convening locally, the importance of connecting between our government agencies, who of course traffic at the state level and the regional level in a lot of these determinants, our private sector healthcare organizations, and our community-based organizations, some of which vary wildly in terms of their capabilities, their resources, and their capacity to even create, much less to sort of consume this information. But they all need to be at the table to inform what we're going to do at the level of data and systems, sort of the technical component of how do we traffic in that. And then also at the level of governance and how are we going to actually make it clear that, again, not just from the hospital or health system side, but at the community-based organization side, what do they need in order to be able to be part of the information flow that then is going to enable the kind of back and forth that's necessary to do this. There's a long road ahead, but there's very deliberate activity happening, and I think it starts to inform some of the work that AHRQ can support.
So thank you. And David, I think to sort of close the loop on the first component of your questions is that this is clearly a top-of-mind problem for, regardless of the stakeholder perspective that people are bringing to the table. So I'd like to move, and we will get to take comments in order. So what I'd like to move into, and Peter covered some of this, some specific examples of where we're active in actually trying to solve this problem. We all agree it's a concept, it's a top-of-mind issue, it's something we have to address. Now we get into sort of the how. So Edmundo.
So, Andy, one of the things I wanted to do, I wanted to put a little plug in because you introduced the idea of technology as solutions potentially, and so that's potentially one of the hows. But I wanted to put a plug in, especially vis-a-vis AHRQ's potential role around technology, digital solutions in this space. So, I think there's a ton of potential in looking at technological solutions. The challenge or the opportunity is that what some of my colleagues here have already said, which is there's very little clarity around the most effective interventions, right? So, and just as Peter said, folks, we're just gonna have to go and start to try some things, right? We don't have time to wait. But I think in parallel, we can start to truly understand what are the most effective interventions. There's some organizations you think of, there's an organization called the Digital Medicine Society, for example, that are starting to, trying to wrap their heads around what the research roadmap might be around understanding this. But so the potential though, the plug I wanted to put in was around equity specifically. As we look at some of the technology solutions, let's focus on equity. One thought here, and I have just a couple of really tiny examples is there's a great potential to decrease equity gaps using technology, using digital tools, right? So you think about, as Beth mentioned, rural cases. Think about telehealth, right? For example, think virtual around rural. Think about a company like Unite Us, which basically creates an EMR for social services, right? So there's opportunities to decrease those equity gaps, but at the same time, there's actually potential to increase the equity gaps by using technology, right? And we have to be very particular about that, right? So think about things like artificial intelligence, right? And basically baking in bias into your algorithms with a black box that no one understands, no one just believes, right? And so I think we need to be very particular about kind of creating a research roadmap around the technology interventions in this space around social determinants.
Thank you. And I think Sally was next.
So I'd like to suggest that a lot of the focus now is on descriptive statistics, it's visualization, it's looking at a heat map, it's standardization of data. That's all terribly important. But I'd like to suggest you really do the thought experiment of what are the methodological questions that need to be answered. And this ties into your point about the research roadmap. And I'd like to suggest you not just do it in the context of health methodology or methodologists in the space. This issue is at the forefront of methodology in the educational space as well. Students coming to class, they haven't had breakfast, how are they learning? And there's a huge focus in education on hierarchical modeling, for example, that might be brought to bear here. On your handout, you talk about small area estimation, where we're borrowing strength across geographical areas. I'm just saying, as you set up the data systems, you have to think about how will they be used methodologically when you get to the inferential questions, which is where we want to go. What interventions work. So I'm recommending that don't allow yourself to get too focused on the present. Maybe it's a workshop where we think about if we could rule the world, what should those data systems look like to allow the best inference? And there's a lot of methodologies that could be brought to bear in this setting from across a wealth of different areas, not just health.
Thank you. I think Greg was next.
Hi, thank you. So I'm just going to say that, again, I think setting matters. I'm a big proponent of long-term care, and I believe that, nursing home, assisted living, community health settings where people are living a long portion of the end of their lives and being cared for by people over time really provides an opportunity for us to understand social determinants of health and their impact on those people over the long term. So those individuals in those settings are impacted by the decisions made to support those settings. So you mentioned technology. So technology in those settings, I believe, is as important, if not more important, including telehealth and health information exchange and those things, as it is for people in acute care and ambulatory care. And in order to develop a system that will be able to collect and transfer data across all these systems where residents in our facilities of long-term care live, and to reduce the burden of documentation across these settings, we need to make sure that they're interoperable and have those data points be consistently collected and consistently measured. As an example, we have a project that is a national demonstration project funded by the Centers for Disease CMS, and it's called the Missouri Quality Improvement Initiative. And in that project, we are utilizing different types of social determinants of health, like transportation, nutrition, access to care, insurance, to looking at those variables and how we can utilize them to help facilities adjust for accepting the increased risk of a patient that is having a change in condition. And the ultimate outcome is to reduce avoidable hospitalizations. And transportation is a huge issue for people in long-term care that are older, that aren't able to get around. And mechanisms to understand what sort of issues they have are really important. And it's important for the long-term care setting, as well as for the ambulatory care and the hospital. So that's just an example. I think these are very valuable things to collect. I think they'll be new to long-term care. And we need to be consistent about how we collect them and use them across settings.
Okay, thank you. We'll go, I'm trying to think of the order of 10 cards. Well, Yanling, Chris, and then Tina.
I like the last diagram that shows patient in control. So I'm not saying really into those control, but I say patient have a lot of input perspective to put how this proceed and how to do this. And I understand, the diagram and it shows overall this disparity and social determinants and how they affect a person's health overall. But different communities also have a different needs, unmet needs and difficulties. And I was just wondering, I don't know how to really think through that, whether there should be, there's overall arching goals and then also regional to address special communities and different disease population, like, patient, for family and patient, the most important thing is how I am doing, my family members doing, whether I can get needed medication, whether I have to spend most of my income to pay house and health care, children's care, then I can go to get my dialysis medication, all these things, So I just thinking in this whole picture, not forget the variety or, the differences among different community. Another thing I've thought about is brought up about the measurements. I think with these things roll out, everybody's so enthusiastic. We're going to do this, we're going to do that. But I think as we go along, I really to see an effort or some plan in place how to measure how, this success. And one of the mechanisms like an NQF or some, private, the organization, I'm on the patient safety committee on the NQF. We are trying to address social determinants, but I don't think it's enough. I think maybe at some stage to include them in the discussions about how to do the measure, because sometimes we have a good intention, but we may have unintended consequences, like I said, cause more disparity or even harm of that. So I just thought measurements is so important. I have done lots of workshop in King County area, Seattle, and I know the consumers and patients are really craving for the data to look at where is the best place I can get a better care. And I think those measurements will put out the data out there when it's mature, available, for people to say the best place I can get a whole person care, in my community.
Thank you. Chris?
Sure. Really where I was going to start, and others have alluded to this, is the critical nature of including the patient's voice all along the spectrum. We have done major course corrections, doing our best work for patients, and then I'm going to say a fresh patient, not our professional patients. We have lots of patient advocates who become part of our organization without realizing it, and we don't realize it either until a patient that's just gone through our system comes to the table and we go, aha, different perspective. So that patient voice. I think the other thing, and this is a big wish, but I think it's the world we live in, what we come up with needs to be simple. There need to be simple tools and simple guidance. I see Jeff on the other side of the room, and Jeff put us through some hoops in terms of some tools that we developed to make them more simple and more simple and more simple. And it was when we got to an infographic that fits on a postcard that conveyed to our primary care providers and patients how they might communicate together better, that some of the folks we worked with said, I've been working with a migrant patient population for 10 years, and all of a sudden they're telling me things I never knew, because the questions have become simple and they've been based on what they said is important to them. So somehow building into all of this, the voice of the people that we want to serve and making it simple.
So just building on sort of that elegant simplicity concept, I think none of these solutions, whether it's technology, data, none of those in isolation work. It has to be combined with an effector arm, and a very simple solution. I know a lot of places have tried this, the community health worker model. Peers out in the community. What addresses these social determinants of health is a ride to the doctor, help with food. Just even a common reason in our system for ER visits is loneliness. Just the peer conversations can help reduce utilization. So again, I think it's the reason this is such a complex problem is there's multiple levers that you have to flip to start to address it. So the last sort of general comment I'll allow Tina to make, and then what I want to do for the last few minutes is just close the discussion with any specific thoughts people have on AHRQ's role moving forward.
So, this is a great discussion, and one thing I just want to bring to everyone's attention is that this is very sensitive data. And so you need to keep in mind who's going to be using this data and where is it going to go. So for example, if you bring your child into a pediatrician and you say there's physical abuse at home, how is that information going to be used? What's the responsibility of the clinician? Does the person reporting this information, do they have the possibility of losing, going to social service, having that information go to social services, losing their child? So I think there needs to be a very structured, conversation about the governance of this data. How will it be used? Because otherwise it won't be reported properly. And so going back to, what's the research question? What are the particular questions we want to do to capture this data? But then keeping in mind how sensitive this information is for these particularly vulnerable populations.
All right. Andy, can I make a suggestion or
Certainly.
request? So rather, in our final lightning round, everybody throw out something. But instead of saying what you want AHRQ's role to be, we'll figure that out. Tell us what you most want. What is the thing that your organization, that if it was provided, would move you the farthest? What is the thing you're missing that could be produced, whether it's evidence, whether it's a tool, whether it's an analysis, whether it's a framework? What do you want? And if you guys want to join in, please do.
Sure. So we'll go around the table. I'll start. I would say sort of building on what Leith said, when you do evidence reviews, evidence that drills down into subgroups, different demographics, socioeconomic, different patient characteristics, that's one need. Two is, with the research funding mechanisms, approaches that allow rapid cycle innovation. That's how you can potentially address this problem. So those are mine. Beth?
I would say what I'm looking for is both secondary data, which comes out of the EMR, because that's being interpreted by a provider across the continuum of healthcare, as well as what Chris was alluding to, is that primary data that comes from the patient. And that's critical in a rural area to have that primary data.
So you'd like tools to help you get you analyze secondary data from your EHR and tools to make sure you're collecting primary data.
Correct.
Perfect.
I would say that for me, it would be research that requires and forces research questions about sharing of data around social determinants of health and the standardization and the use of those so that we can more properly identify how they can be used across the continuum, including long-term care.
For me, I think it's very important for me to know what can we, patient and family, can do as a part of the equation to resolve the problem, and where can I get the best care and high quality and less cost without the insurance restriction.
Oops. I guess from my standpoint, there's a lot of variation in the country, just overall in terms of healthcare and how we're providing it. There are pockets in the country that are that you've heard about that are very aggressively pursuing the determinants of health / population health, et cetera. But there are elements, regions probably in the country that aren't really pursuing those concepts. They're just trying to deal with the immediate issues that they have and to try to help those areas that aren't able to progress quite as quickly as other parts of the country. I think that would be important.
So for me, it's always about the data. So, I mean, the biggest attribute that would really advance it, I think, is really granular data from diverse populations, diverse geographical locations, diverse healthcare settings, and even outside of the healthcare system. You know, so we can pull some of the information from the census data, but it's not linked to anything that we can actually use in the healthcare system. So really, just the granular data across diverse populations is a huge, I think, barrier to moving this forward.
Great. I think for my members, medical groups and health systems, probably just dissemination of what's currently going on, how people are addressing this, what they're measuring, the outcomes. So really unearthing what's out there right now would be very helpful to them.
So awareness. So an awareness building of what's already out there that they could use and model on.
Exactly, environmental scan.
So I was struck by an equation on your slide, Leith, which is a small equation, zip code greater than genetic code, which I hadn't seen and I really like. And I think AHRQ plays a real leadership role here. As again, I'm a statistician, so methodology, that's what I think about. I think there's tremendous focus of funding on methods that are making very little change. This is where the variance is. So I think the swing should be toward methodology and analytic methods that are going to solve this problem rather than what are small problems in some sense.
I think whatever you can do, at least from our perspective, in terms of measurement of performance would be very useful. The tools that the government uses now, particularly CMS, are becoming more a matter of compliance than a matter of either improvement, true accountability, or even worthwhile as transparency for patients and consumers. So anything we can do, and sort of along, maybe coming from what Tina was talking about, anything we can do to actually move us towards measures that are actually meaningful, not caught up with the current rhetoric about meaningful measures, which just mean fewer measures, which usually aren't very meaningful to improving care.
So my wish is that you put on your policy hat and raise awareness among not only funders but policymakers about how difficult this is, about the risks of embedding bias in the latest cure that many of our organizations see on the horizon, whether it's AI or machine learning is going to be the answer. I think a credible voice needs to point out some of the limitations and that we're not quite there yet with that being the solution. I think the other thing from an awareness as a healthcare system, I would love collaborative learning opportunities. I don't know what shape those take, but there is activity happening everywhere and an opportunity to learn from and with others as part of the whole learning health system mantra would be a step forward for us.
So Edmondo Robinson, I'm thinking about, and maybe it's, I think I got inspired by Sally here, but I'm thinking about a research framework and roadmap, actually, that includes what we already know, which, because there are some data out there, kind of talks about what remains outstanding and what truly can be translated to everyday practice on a kind of a broader scale. So what I'm thinking about is, how do I charge my team with really figuring this out? But I'd love to have a framework to do so.
So I can probably, being at this end in the home stretch, echo almost everything everyone has said. But to what Armando just and Chris just raised, I would say specifically on the data front, the ability, you can think about quality and safety improvement, you need to be able to track and trend progress to see if what you're doing is actually having an impact, because you don't want to keep doing the things that aren't having impact, and it's actually a way to inspire greater buy-in if you can demonstrate progress. And I can tell you right now, I don't think we have. Does anyone know how to do that? I don't know how to do that, so that would be great.
Yeah, and I could say ditto also. I would say, if I had to really focus in, and many have said this in different ways, the development of good evidence that would inform best practices for the various stakeholders that are involved across the spectrum, to inform our decisions around investment, adoption, implementation, and then policy. And importantly, I'll add, because I don't think we've said it quite explicitly, but how this affects the way we pay for care and how we pay for health. I mean, fundamentally, it's not something we've stopped talking about as a nation, but it continues to be at the crux of this, because if we don't align the incentives appropriately, then with all the best intentions, we're not necessarily going to be able to align the various parties that need to cooperate and ultimately adopt the practices. And that has to be done ethically with an eye toward what's effective. And so AHRQ is in a great position, I think, to help us develop that evidence base.
Thanks. As a sister agency to AHRQ, I find this conversation very stimulating, and wondering how we can assist you better to build on our traditional strengths, which are surveillance, research on effective public health interventions, and traditionally we've really worked with public health partners, but we are moving more towards integrating public health with health care. And so what could we do in the area as an example of surveillance? We already are very interested in tracking social determinants of health. We are not the original source of data. We get our data from our state and local jurisdictions, but nonetheless, we put it together. We make that available. We're interested in small area analyses. And we tie that to other layers of data like health outcomes. So just exactly what you're talking about, maybe we could help you there, although I'm not in a position to commit resources. I'm just thinking outside the box here. On interventions, you know, a really good chunk of our budget goes to state and local health departments to carry out those interventions. So they too, we're just as interested in making sure that the interventions that are used are effective, you know, in the public health department, but also in the healthcare setting. So how could we blend that and marry that together? And then on the integration of healthcare with public health, which is new for us, we are in the space of informatics. We are interested in electronic case reporting for disease surveillance instead of collecting the data more traditionally or supplementing it with that. How can we get, I mean, as you all were talking about the primary data collection and the electronic health record, maybe that some of those data could help us with putting together the bigger picture of surveillance nationally and also at the small and local level. So if we could use some of those data and supplement that with what we already collect, maybe we could help methodologically to put together pictures and then do the etiologic research about what is really important in terms of social determinants of health and how can we have effective interventions along those lines. So you know, I think that there's a lot of opportunity to integrate even more closely with the healthcare sector than we have, and that is really how we're thinking about moving forward. And I think actually we don't have a choice. You know, with this is now medical records are now really being seen as a cost-effective way for doing surveillance, and so if we have to be in an environment of fiscal constraints, we may actually all find it beneficial to be more partnering on this.
Thanks, Robin. And we look forward at AHRQ to helping you with many of those questions. I'm going to ask you on your way out and as we can, and for the rest of the team to think about what do you want AHRQ to do to move your work forward. You did a great thing of what you could do to move their work forward, which I love. But an added benefit is to hear from our sister agencies of how can we be more valuable to you as we create our framework. So Sherry.
Yeah, thank you, and thank you for the robust discussion. So just very briefly, from the CMS perspective, what would be really helpful is to be able to deliver to exactly what has been requested here. Because really, ultimately, and honestly, you know, real improvement is local. And that is, whether or not it's just addressing social determinants of health or if it's about patient safety or all of the above. So we clearly recognize there is not going to be one solution. So how do we enable the evidence to support the programs and implementation really at the ground level? I think that is what is key. I think what we have enjoyed in the past is the collaborative approach that we've been able to build on the evidence, you know, pointing to what are the real gaps in care, and utilizing our abilities as a information disseminator to provide technical assistance, to provide and implement and build the quality metrics that really are meaningful. But again, meaningful measurement has to be meaningful to those who are actually using them, delivering the care, because when all is said and done, it's about the person receiving the care who is sometimes a patient when they are in that role, but also all of us who provide those care and services. And one final point, I think we have learned over time how important the tools are that AHRQ has built, but what the tools are, they're not just the box or the gadget, right? It's what is implicit in those tools. It's about how we change the culture of providing care, and some of that we've learned and really enjoyed the benefits in the culture of safety. And even challenges as difficult as social determinants of health and bias and all that, if we actually can make it visible and then illustrate how the culture, because it's about behavior change. But again, it gets back to what it is that you all need to exact those type of changes in a way that really meets the needs of the beneficiaries who you're serving. So thank you for the opportunity to comment.
Thanks. Well, this is something that
the VA is grappling with as a health system. And I think it's important to recognize, this isn't new at all. I think what you're bringing to the table is getting the healthcare sector involved in something that they hadn't typically thought was their responsibility, that it was either the public health or the education system or someone else's responsibility. And so as a result, it won't be solved alone. And I think your role, the most important role could be taking an area and demonstrating you can actually make some progress in it. Because I think that because it's not new, the biggest barrier is just feeling like it's not solvable. And I'm thinking so models of partnerships at a county level, the sorts of things that King County has done in Seattle, but around an issue like maternal mortality. Take something that is going to cut across sectors where you have to break down silos of what's paid for by the healthcare system, what's paid for by the social services system, because the issue is that there's a lot of money sort of being sloshed around on these problems, but because of the silos in who's responsible, who feels they're responsible, or who pays for what, we're not able to direct it in a way that we think will have the biggest benefit. We've had an interesting example where we have in our system community health worker interventions that have been successful, but we've had trouble scaling them because in our system it doesn't generate savings that we can capture because we're sort of a capitated system. So I think obviously the data and everything else would be nice as well. We're wondering how to collect it, but I sort of think of the hospital-acquired infections as an example. I mean, those were a problem for a long time. It wasn't until we showed that we could actually change the hospital-acquired infection rate that people said, oh, maybe we should measure this, maybe we should pay attention to it. We thought it was just the price of doing business. And I think there's a lot of that same sense that inequality has always been with, the poor have always been with us. So until we show that you can actually find a way to redistribute the resources that are in the system to get a better outcome, I think you'll always have an uphill battle. But I do think there are opportunities and maybe focusing on a specific one. For the VA, it's suicide. We're not going to solve the suicide problem in the VA by getting healthcare providers to do a better job screening. We have to go upstream, and we're trying to figure out what that looks like. How do we work with community organizations to go upstream and solve the problems of social disconnectedness and lethal means? And it's not something that's there's an economic model to make it viable for us to take on alone. So I do think, trying to show a business case for all the different parties, you have to come in and ask to do work differently.
Okay, well, I wanted to thank Dr. States and Dr. Myers for their presentations, their thoughtful input, and also the group for what was a very rich discussion and hopefully useful in terms of AHRQ's sort of future work. So appreciate everyone's input there. I believe we do have a public comment. And I will ask Laura Marcial from RTI. Okay. Just make sure the microphone's on before you start.
Is it on? Yeah. Thank you for using my phone just to help me queue up my comments. So I'm Laura Marcial. I'm a PhD health informaticist at RTI International, and I've been working on several AHRQ initiatives over the last several years, including the CES portfolio, and in particular the Patient-Centered Clinical Decision Support Learning Network project. I'm not here speaking on behalf of RTI, I'm just here as an individual. But as a subject matter expert in the CES domain, I'm here to advocate for and support the notion of AHRQ continuing to take a lead in the future vision of clinical decision support. I've served on several working groups over the last 4 years from lots of different perspectives, looking at barriers, facilitators, and recommendations about advancing CDS, and strongly agree that trusted, shareable, interoperable, and extensible CDS is urgently needed. I use the word urgency because in a CDS working group meeting just recently at AMIA, an FDA representative sort of came in and said, hey, do you understand how bad the data is at the data collection level? And we were sort of like, yeah, we do, but that we have to work it from both directions, sort of from the middle layers and from the bottom or the origination layer. Despite an intuitive sense of the impact of CDS, the ROI for CDS still remains elusive, and that's further complicated by this fragmented environment in which we operate, where CDS is developed and implemented. In order to systematically evaluate the impact or outcome of CDS, we really need to improve the systematic development and implementation of it. And to do this, we need sustained, supported, systematic access to these resources. And conversations about a model for doing this will really need to include public-private partnerships in order to generate the kind of multi-stakeholder engagement we really think is needed to meet the future vision. Thank you for the opportunity to comment.
Thank you. Okay, and with that, again, I would like to thank the NAC members, Gopal Khanna, Ginger Mackey-Smith, Lucy Levine, Ed Lomatan, Leith States, and David Myers for their presentations. I would also like to thank the AHRQ staff, the audience who attended in person, and anyone who participated via the webcast. And once more, we appreciate the 7 retiring NAC members for their service, and we look forward to working with you down the road on this care quality improvement journey. Just before we wrap things up, are there any other comments from NAC members about the topics we discussed today, or, and I think of specific interest would be topic nominations for future meetings? Yes, and then also, just remember for retiring members, just a reminder, pictures, group picture with Gopal, and then an individual picture as well. So they will be convening at the lunch break. I think today, just one comment that I would have in terms of future topics, I think the sort of the cross-divisional conversation was very enlightening to me. And so one thing that I would, actually 2 areas that I would think would be potentially useful. One would be the intersection of NIH and some of the personalized medicine, and then also with the implementation science, because that's obviously a key area for AHRQ. How do we do a better job coordinating and aligning that work to advance the science in that area? And then the other would be in terms of the rich discussion with social determinants of health. Can we tie that into other current AHRQ initiatives, such as diagnostic safety? Very basic things. I think everyone in the room would agree that social determinants of health can play a role in diagnosis in terms of access to health care, interactions with providers, and I think that would be sort of an interesting component that would tie into existing AHRQ work that is being supported. So any other comments or ideas, topic nominations?
Yeah, hi, it's Don on the phone. I'm driving, so I couldn't warn somebody.
Hi, Don.
To say something. Hi, just real quick, and this will be perhaps less controversial. It seems to me there are 2 important things. You've mentioned one of them, the action mechanism, which is really a potent mechanism for change at AHRQ, have the language of improvement science, implementation science, whatever you choose to call it. Obviously, the federal language now is implementation science. And it's going to be interesting to see how the grantees take that seriously and whether they really use the full repertoire of implementation improvement science methods in their work, which increasingly include looking at implementation outcomes. In other words, the actual predicted and achieved outcomes as specified by the activities in the grants, and how they embed evaluation and collaboration between design and evaluation in their work. So now that we've adopted that as a language and are making those links, are we going to have a high degree of fidelity actually using them in the grants that are put out? The other has to do, I think, with a mission-critical issue of collaboration with the private sector, public-private partnerships. And I know that HRQ is very interested in that. Gopal particularly made that point a number of times. But it is difficult, and what's going to make it more difficult is the pace of development of platforms by small venture capitalized firms that are trying to grow and get bought up by bigger firms. And if you look at the social determinants, for example, there are at least 3 pretty decent platforms I'm aware of that come out of the private sector that are trying to achieve that match between what a patient needs as reference from a health assessment and what services are available. And increasingly, they're starting to close the loop on that and determine whether or not those needs were actually met and the appointments were actually made. So how do you keep up with that? How do you evaluate it? It occurs so fast. The adaptation is at lightning speed. So what do those partnerships look like? What's the right level of a partner? It's hard to really partner with small venture capitalized firms that are trying to make it. But it's even harder to have authentic relationships with Cerner and Epic and the huge companies that also have a business model. So just something to put on the radar to explore. Thank you.
Great. Thank you, Don. Okay, I do not see any other, so we do. Chris.
Very quickly, I think for future agenda, I don't have this firmly formulated in my head. I would like to hear us talk a little bit about clinical burnout and workforce issues related to the coming generation of healthcare deliverers, if you will. And also in the AHRQ populations, we talk about women and children, but I increasingly read and am concerned about the lost generation, the teenagers and the 20-somethings that when we look at are being caught up into our opioid epidemics and others. And I don't know where that fits in the research spectrum, but I'm thinking about that related to workforce as well. So if there's a place for provider burnout and workforce development in the pipeline for who's going to be caring for me and others in the future, if that fits in the agenda.
So
I'd love for
maybe
us to
more
get to-
broadly, just sort of reframing and re-examining the priority population, including providers.
Maybe,
And,
yeah.
you know, I mean, that would be a potential topic. Okay, very good. All right, the next NAC meeting is scheduled for Thursday, March 26, 2000, oh, I'm sorry. Gang Ling.
I just wondering if there any value to think about a community type of a survey directly from the consumers, from patients, about what the gaps and what are missing in this upstream care. You know, people have different needs and unmet. That would really help the local, if you involve the local stakeholders to really help to implement whatever the plans out, and they have to find out what the solutions are for my community. I don't know what the time frame would be, but I think voices from them, the consumer side, patient side, family side, is extremely important to shape the future how care delivered.
Okay, thank you. All right, so I don't make the same mistake again. Any final comments? All right, next meeting, March 26, 2020. I will turn it over to Gopal one last time for the announcement about the afternoon festivities.
First of all, thank you, Andy, for being such a wonderful chair, and thank you all NAC members for being here today. It's been an exciting session. We do have, now that this session is adjourned and complete, I do want to urge you to come back around 12:40. We'll have a little celebration of AHRQ's 20th anniversary. So please do come back. We'll have Deputy Secretary Eric Hargan joining us as well. So by 12:45, please. Back in the room again.
Okay.
Thank you.
Thank you. So with that, we will wrap things up. I wish everyone safe travels wherever they may be, and a happy and healthy holiday season with friends and family. So thank you all, and we will close the meeting and officially adjourn.
Thank you so much.
Thank you.